SS Arya.
Yes.
Yeah, and she's going to talk about bilateral malignant glaucoma. It's a wonderful topic, and I'm sure we're going to do justice to it. Go ahead.
Thank you.
Don't waste your time.
Good morning. Good morning, one and all. So I'll directly move on to my case. My patient was a 69-year-old male who was a farmer by occupation who presented to the acute emergency with complaints of sudden onset, profound loss of vision in both the eyes for past 4 days. It was associated with redness, watering, photophobia, and headache. There was no history of similar episodes in the past, no history of any trauma, use of any ocular medications, or any other ocular surgeries. On examination, his distant visual acuity in right eye was hand movement close to face, and in left eye was finger counting at 2 meters. The extraocular movements were normal. Anterior segment examination showed lid edema in both right and left eye, circumcorneal congestion in both the eyes. Cornea showed epithelial and stromal edema. The pupil were mid-dilated ovally, sluggishly reacting to light. Iris showed atrophic patches. There was no NBI. AC was shallow throughout and with Van Herrick's grade 1 depth, and lens showed grade 2 nuclear sclerosis. The fundus was hazy due to media opacity. By Goldman applanation tonometry, the IOP in the right eye was 32 mmHg and in left eye was 28 mmHg, and the CCT was also recorded. These are the anterior segment photos where we can see the corneal haze with the ovally dilated pupil in both the eyes, and the conical section photo where we can see the shallow anterior chamber. So in view of the above findings, we came to a working diagnosis of acute angle closure of both eyes, and he was started on IV 20% mannitol that was given 12 hours apart, and simultaneously he was also started on hydropilocarpine, oral acetazolamide along with other topical anti-glaucoma medications. However, to our surprise, the patient did not improve, and not only that, his symptoms had worsened. So we went on to further investigations, and on ultrasound biomicroscopy scan, we found significant ciliary body swelling, and we went on to do a USG-B scan where we saw exudative RD. We went on to ask few more questions to the patient, where he came up with history of seizure episodes, last episode happening 1 month back, and he was started on tablet carbamazepine by a local clinician. Thus, we came to a revised diagnosis of malignant glaucoma both eyes. Hydropilocarpine was stopped immediately, and he was started on atropine along with timolol, oral acetazolamide, oral and topical steroids. He was evaluated by the medical specialist and was diagnosed as seizure disorder. Then post-treatment, we could see the anterior subcapsular opacities, clear cornea, well-formed AC, and the iris atrophic patches. The IL-Master 700 was done that showed normal axial length parameters in both the eyes. The posterior segment photo shows a resolved exudative RD, and a post-repeat UBM scan shows significant reduction in the ciliary body swelling and a wide open angle. Thus, I would like to say that such a case of spontaneous and bilateral malignant glaucoma is rare. And why my case is malignant glaucoma? Because on examination we saw that there was shallow AC throughout, and the patient had worsened with miotic treatment and improved with atropine. And on UBM we also saw significant ciliary body swelling that was a secondary cause. So the take-home message would be that in case of shallow AC, we have to think of other secondary causes, and yes, going back to history made all the difference. Thank you.
Could you explain what is the cause of the anterior subcapsular opacities and patches of iris atrophy also?
Yes, sir, probably we believe that the patient might have had previous attacks of acute angle closure but was not noticed by the patient. There might have been a pre-existing acute angle closure.
Patient had the previous subacute attacks of angle closure initially, and you think that following initiation of carbamazepine for his seizures,
yes, sir,
the patient developed malignant glaucoma.
Yes, sir.
Is it documented in the literature?
So there have been cases reported where there have been angle closure with raised IOPs with carbamazepine and gabapentin, sir.
Angle closure,
Angle closure, sir.
but not malignant glaucoma.
No, sir.
So how did you this thing come at the arrive at the diagnosis of malignant glaucoma in this patient? Just because of worsening with pilocarpine?
No, sir. Also, the UBM scan that showed a significant ciliary body swelling that was seen in the UBM scan, sir, that made us come to a
Any
diagnosis.
rotation of ciliary processes?
Yes, sir. That was noted. That was noted in the UBM scans.
Yeah, Ishu.
What is the axial length of the eye, and do you think that matters?
Yes, ma'am, because that also again is a predisposing factor that can lead to anatomical predisposing factor that can cause malignant glaucoma. In this patient, it was normal, ma'am. It was 22.03 and 22.3 in the left eye, right and left eye.
So then in that case, how would you clinically differentiate? Because what I understand is like over here, the diagnosis of malignant glaucoma is a little gray area. How would you clinically differentiate, let's say not this case, a typical case of malignant glaucoma versus an angle closure glaucoma? Clinically, how would you differentiate the two?
Acute angle closure, ma'am, of course, the patient usually improves with normal conventional.
Would you
anti-
like to do some intervention in order to then check back?
Yes,
With
ma'am.
what intervention?
A
would you
YAG
like to-
PI would be should be done, and we can see whether the patient improves with it or not, which usually improves with acute angle closure, whereas the patient usually does not improve with malignant glaucoma.
Any difference in central anterior chamber depth and the peripheral?
Yes, sir. Yes, sir. In case of acute angle closure, the AC is shallow peripherally, whereas it is deep centrally. In case of malignant glaucoma, it's noted that it is shallow throughout.
And any investigative procedure where you can really find out besides UBM?
ASOCT, sir, and known as a non-invasive procedure. Initially, ASOCT can be done. In our patient, we couldn't do it because of the corneal haze initially, corneal edema.
Fine. It's a very good case.